But I do want to finish up with one case here, which was what can happen after transplant. And so this patient was a 78-year-old male. He had HCC. And after transplant, he developed a biopsy-proven left adrenal metastasis. So what sort of options do we have systemically post-transplant?
Well, I've said it 3 times now, so hopefully it's getting across. No immunotherapy post-transplant. And there are case series showing fatalities in this circumstance, both in HCC and in other tumor types. And, unlike patients that are post-kidney transplant, for example, where we have dialysis as a backup, if someone rejects their liver on immunotherapy post-transplant, we're in a really bad place. So that does leave us towards additional mechanism of action. So as you mentioned here, this patient was challenged with lenvatinib. We don't have great data in the post-transplant space on which systemic therapy to use. So we're kind of just putting our best thinking caps on from, again, a mechanism of action perspective and what do we use in advanced disease. I would say most people agree that lenvatinib is the most active TKI in advanced HCC, which is why that was chosen.
And he did well for 2.5 years, though eventually did develop intolerance from a side effect profile, for which we then did a cryoablation. And now you can see on a post-cryoablation, he has no evidence of disease, as far as we can tell, about a year out off of all systemic therapy. I just wanted to have a quick conversation about how we can treat these patients post-transplant.
I have one patient who had an adrenal met who did well with SBRT as well. Yeah.
I mean, I think you have to be careful, and we probably would have done the same thing. If they get an immediate recurrence, jumping into a local regional approach before systemic approach is probably unwarranted, right? Because, okay, I see this one adrenal met. Yeah, we can technically treat it, and then 3 months later, they have 5 lung mets or 3 other adrenal mets, right? So it's they need some kind of systemic approach, assuming they can tolerate it. And I would argue not just a systemic approach, but then some demonstration of stability before you consider doing, let's say, a percutaneous ablation in this case, okay? Because I don't want to just jump into it and find out on the next scan that you were just treating 1/10 of the patient's cancer cells in the body.
You haven't helped that person.
You haven't helped at all. Yeah.
What does stability mean? 6 months?
Yeah, it's
5
like
months.
A good long time.
5 to 6 months, right? No, so I mean, at the very least, 3 months, because if you just assume that we often restage patients every 3 months, right? Which again, there's no reasoning to do it every 3 months, but we do that, right? So at the very least, I want a 3-month scan showing some relative stability where this patient didn't blossom out with 5 lung and bone mets, where doing a single adrenal cryo was really not worth it for him.